So without further ado, we'll get started. And so in the terms of the talk, what I want to do is, first of all, sort of give you a basis for the treatment and where we're using adjuvant treatment, but then talk a bit about radiotherapy, how it's done, doses and things used, and also timing, of course, after an operation. And then illustrate what I've talked about with a few cases that we've had recently. And then talk a bit about systemic treatment as well, because I think this is something where we are going to be using it more and more because of the sort of molecular markers and testing that we're doing that Nick alluded to. But I think no apologies, for repeating this, that we are dealing with a very diverse group of malignancies when we're talking about the parotid. But I think, although we have this complexity, we still very much have the standards of care in terms of how we break it down. So we don't need to learn a management schedule for 33 different diseases, that there are the common themes like the grade of the tumor and also the ability to resect it and the pathological factors we get from the time of the operation. But this is sort of an overview of essentially, how my mind works when we're talking about malignant salivary gland tumors in MDTs. And like we do pretty much with squamous cell carcinoma of the head and neck as well, that when we're dealing with early stage or low-grade disease, then generally we're looking for a single modality of treatment. And in salivary gland malignancies, that is always surgery. Surgery is the primary modality of treatment. And generally, when you have early stage or low-grade tumors, you are looking to cure them with that modality alone. But there may be indications because of proximity, to, for instance, to facial nerve, et cetera, where you might be forced to consider bimodality treatment if positive margins or there's other concerns that are discussed in the MDT. But very much when you get to the advanced stage disease or the high-grade tumors, that's where with very few exceptions, and some of those are patient factors, but also tumor factors, you're always thinking about bimodality treatment. But again, surgery is the cornerstone of treatment, and the radiotherapy is given adjuvantly. But of course, as I saw a patient last week with a carcinoma ex-PSA, an 84-year-old gentleman who's still fit and well and would be very much fit for an operation, his mind was he did not want an operation. So, he just was not going to contemplate it. So he came to me, and I actually said to him, because he has no symptoms in this and it's not growing, there's two options here. One is, yes, I can give you radiotherapy as primary treatment, but, surgery would be the preferred option. Or we just watch and wait for this, and he's opted to have radiotherapy. So I think we should always consider it as another option for care, but it's certainly not the best option for care. But it could be where patients are having symptoms and have fungating disease where they're not suitable for an operation, or they decline that kind offer. And I think there's also the ideas I've said already about systemic treatment, but not as a combined modality. And this is where malignant salivary disease is very different from squamous cell carcinoma of the head and neck. But it can be very useful palliation. And as I say, I will talk just very briefly on that. So I think, as you've probably heard throughout the course of this afternoon, is that the management of salivary gland malignancies, there is no randomized controlled trial evidence for what we do. And that's the same in terms of the reasons why we give adjuvant radiotherapy. They're based on, but quite big series, as you've seen, on clinical case series and retrospective reviews. Okay. But what we know in the rationale for giving adjuvant radiotherapy is that radiotherapy is extremely good at sterilizing small numbers of cells that might be left within the tumor bed or within the patient at the area where their cancer was after an operation. And that's why it works. And the smaller number of those cells, the more effective the treatment will be as well. And this obviously looks very old because it is now, several years or a couple of decades ago. But I think it illustrates very well is that, I could keep adding studies to this, but this is where it shows that clear advantage in patients who need bimodality treatment of what we're giving to our patients when they require the adjuvant treatment afterwards, that there is a significant improvement in outcomes when you combine the treatment. And I think if we think then about, going back to this point I said about early stage, low grade, only single modality treatment, but high grade, late stage, you're wanting, to combine treatments, then thinking about breaking that down and what are the particular characteristics or sort of factors that we look at that require adjuvant treatment. Well, this is a good paper, again, now, nearly 15 years ago, but this looked at the Dutch cohort of over 500 patients over about a 10-year period. And they looked through those patients and discovered, what are the particular things that are of interest. And it won't surprise you that, these are the same things we use when we're talking about squamous cell carcinoma. So it's the same sort of ideas apply as they do to all cancers, whether we moved into a breast cancer talk or a lung cancer talk, that when you have late stage, when you have high grade, and if the patient is having primary surgery, if there's closer involved margins, those are all things and rationales to consider adjuvant treatment. And likewise, the perineural invasion, that again, what we see in adenoid cystic carcinoma, or if the person has bone invasion, because obviously that means they're higher stage without fail. And also if there's node-positive disease. So the clinical evidence, statistical evidence that those patients significantly benefit from having adjuvant treatment given to them when it's appropriate to do so. But with the early stage tumors, the T1, T2s, really it's additional treatment if the other factors are clear and those tumors are completely excised. So adjuvant treatment, radiotherapy should be considered where you have advanced stage disease, and that's irrespective of grade. Okay, so if you have a low-grade T4 tumor, we would want to give that patient radiotherapy if they're accepting of it. And of course, the positive close margins, the high-grade tumors, and where you have perineural or lymphovascular invasion, that is an indication to consider treatment. And of course, lymph node involvement, because that means a higher stage. And also recurrence after previous surgery. And that includes the pleomorphic salivary adenomas as well, okay, as a benign condition. And then in adenoid cystic, this is sort of the exception to the rule. So if you have an early stage adenoid cystic, and it's completely excised, margins are very generous, you are still going to want to give those patients radiotherapy, because the evidence is, irrespective of margins in those patients, they do better when they have adjuvant treatment. But it's about local control, because as Nick said in his talk, a very high percentage of these people will have local control taken care of, but then lung mets or liver mets or bone mets will pop up. But those patients still have survival, oftentimes measured in decades, so that local control is very important. So in terms of myself and what I think about the sort of neck management, then it's again, the same things apply as we use in squamous cell carcinoma of the head and neck. And as surgeons, you're thinking about whether to do the neck dissection or not, because it's those same risk factors that increase the risk of local control that also increase the risk of nodal metastases. So in terms of the adjuvant treatment, I would be using those factors to determine whether I should just be treating the tumor bed or treating the ipsilateral neck as well. But there would be no real, I can't think of any indication where you'd want to treat contralateral neck unless, of course, you've got bilateral disease. So in terms of what type of radiotherapy, well, the mainstay, no matter where you are in the world, is photons. So it's X-rays. And nowadays it's IMRT, because that's essentially the standard of care. And although there are places in the world that don't have access to IMRT, radiotherapy machines, that is the standard of care where they are available. But I think there has been for quite some time interest in things like fast neutrons or protons and carbon ions and things such as that. And those are not being used as standard anywhere in the world, although, obviously where people have access to them, they will be used, but it's not seen as a standard of care in guidelines. But I think the important thing that is on the horizon now is protons, and that's because we now have the Christie in Manchester. They've opened their proton machine and are treating patients, not salivary gland patients at the moment, but that is available to us now. And there is some evidence that that they can improve local control because we can give higher doses at the same time as reducing potentially the consequences of surrounding normal tissues. But it's not funded, and as I say, although available, I think we should be looking to try this in a clinical trial, about standard of care, because what you might get in terms of improved normal tissue side effects, there is going to be a price to pay in other ways, whether it be financial or in terms of access and logistics for the patient. But there isn't really the suggestion there'll be a significant survival advantage. So IMRT is what we use, and IMRT is now the standard of care for pretty much all radical head and neck radiotherapy, thankfully. And it's because it gives us this ability to be much more conformal or shaping our treatment so we can reduce down significantly the high dose that we're giving to normal tissues. And so it can reduce the radiotherapy toxicity and the dose to the surrounding normal tissues in terms of late effects. And also what it allows us to do because of these factors is on occasions re-irradiate. And that might be because of a second tumor the patient might have or relapse many years down the line. What about the timing of radiotherapy after surgery? Well, the ideal is it should be within 3 weeks, 3 to 8 weeks, but 3 weeks pretty much is an impossibility because of getting patients through the operation and then seeing them again in clinic because how our services run in the NHS. But it definitely should be less than 3 months or 12 weeks, because I think by that stage you've really sort of lost the benefit of what you're hoping to achieve. Although you make you make that decision based on the individual patient. But if you have a patient, of course, who's not able to start their treatment or, really be into their treatment by that time, you've got to ask the question about, are they actually fit to have the treatment? Because it often has meant they've had a significant and quite stormy post-operative course, for instance, or there's other factors that would preclude giving adjuvant treatment. So as I say, the goal is between 3 and 8 weeks, and I know within Sheffield and South Yorkshire practice, we pretty much get there in terms of 4 to 5 weeks after treatment starting patients. And in terms of what dose we use and the fractionation schedule, well, typically it's 2 gray per fraction, which is the sort of standard in all head and neck as well. But there can be indications of giving shorter courses depending upon the volume. So this old chap, the gentleman that I discussed who did not want surgery for his carcinoma ex-PSA, is very small. It's less than 2 centimeters, this lesion. So I'm going to give him 55 gray in 4 weeks, so in 20 fractions. And that potentially has this sort of hypofractionated regime, has benefits in terms of tumor control, but it will also mean a much smaller volume for him, and hopefully his concern is coming back and forth, even though he just lives up the road from the centre. But usually, depending upon whether it's an adjuvant treatment or a primary treatment, it's between 50 and 70 gray is the amount of dose we're giving in 2 gray per fraction, as I said. And I think just to emphasize again is that nerves are actually really resilient to radiotherapy because the doses we're using are usually below their tolerance. So if you have had to do a nerve graft, these patients should still be offered, because pretty much they are on the high risk spectrum, they should always be offered post-op radiotherapy, and you should not be concerned that your nerve graft will die as a consequence of that. It will survive. So in terms of what are the things I'm thinking about when I'm planning the radiotherapy, well, there are a few specifics in terms of, especially in the parotid gland as well, and it's making sure that we include that peripharyngeal space deep, because that's often where margins can be positive and where there's a high risk of the recurrence happening. And for the same reason, it's that deep excision margin and where that's closer involved, especially when the facial nerve has been preserved at the time of the operation. And specifically in adenoid cystic carcinomas, we always talk about this. It's something that's more difficult to do, but where possible, we try and include the course of the nerve up to the level of the skull base or even beyond in certain patients, depending upon the primary site, because that is often where, again, margins will be positive and there will be a higher risk of microscopic disease present there. But of course, that does then increase the potential side effects for the patient as well. And so side effects, obviously, radiotherapy is a localized treatment, and the side effects do depend upon where we treat and whether we're treating ipsilaterally or whether we're treating beyond that. And the side effects will always be related, not only to the dose we're using, but to the size and location of where we're putting the radiotherapy dose. But of course, many other patient factors as well have to be taken into account. Patients who have diabetes or cardiovascular disease are going to have worsening side effects, and it will take longer to develop. But as you see from the radiotherapy view there, that the dose, the actual dose end of the treatment is very well conformed, and so that the mandible in this case is getting very little dose, that the spinal cord is getting very little dose at all. But the patient will, for instance, have a degree of pharyngitis and soreness and swallow because of the treatment and where it is, and the skin will get very red, but only in that area because we are bringing the dose up to the surface, so we want to get that skin erythema, otherwise we're under-treating that area. So as I said, I've got a couple of cases just to sort of illustrate that. And this first one is a lady from, I think she's about 2.5, 3 years ago now, and she's actually a GP from Sheffield. And she presented, she's a very slim lady, and she presented with a lump that she felt under her left chin area. And there was this small area, as you'll see, sort of very bright in the left parotid there. In the left submandibular gland there. And she got up, one of her colleagues in the practice referred her up for an ultrasound scan. And the report from a very experienced clinical ultrasonographer, actually one of our dental radiologists, felt that this was a benign adenoma, but did a biopsy anyway. And the biopsy actually showed it was an adenoid cystic carcinoma. So discussed in our MDT, and the management plan was surgery and then followed by adjuvant radiotherapy, because again, we weren't going to wait and see margins or grade or anything. This is adenoid cystic, so we know this lady's going to need adjuvant radiotherapy afterwards. And so she had surgery, and it was less than a centimetre, a cribriform type with no solid component, but the deep margin was very close, as was the superficial margin, but it wasn't involving skin. And she had a neck dissection, and that was clear, that the neck nodes were all clear. So staging-wise, and then radiotherapy, again, documented through the MDT. And so this is how she's treated. You've already seen the axial image on an earlier slide. And because of those positive margins, I've actually given her 66 gray and 33 fractions over 6.5 weeks. And the interesting thing, I think, in these patients, and again, comparing them to the normal squamous cell carcinomas of the head and neck, is this lady really suffered with side effects in terms of, even though her volume was very small, often it's because the patients don't have those same characteristics as our SCC patients, with the drinking and the smoking and things. And she really was sore and off of food and things like that for a number of weeks. But now, as I say, I think she's about 18 months out now. She's back to work. And fully recovered from this, and very little in the way of longer-term morbidity. But she does remain at risk, of the problem coming back, and especially elsewhere, which she's aware of. But we're not imaging her. We're not following that in that way, because she understands the sort of psychology of worrying about what scans show. The second case is a 71-year-old chap who presented with a painful lump in his right preauricular area. And he had no past history of malignancies, because I think it comes back to, again, the point from Nick in the previous talk, was that this was biopsied and shown to be a high-grade squamous cell carcinoma. So the immediate thing we think of in older patients is about whether this is a metastasis from a skin cancer. But he had no history of that at all. And he had all the imaging, including PET scan and things, to find out if it had come from somewhere else. So by a process of exclusion, because we couldn't blame it on anywhere else, we've had to say that this is a primary SCC, but these are very, very rare. But again, irrespective of the rarity, the treatment is surgery, and then defined about adjuvant radiotherapy. But we knew that there was a high chance this chap would need radiotherapy because sort of the extent on imaging. And he went for a parotidectomy and had a level 1 to 3 neck dissection. The neck dissection showed that there was no nodes positive, but this was a high-grade squamous cell carcinoma. There was evidence of vascular invasion, and margins, again, were close because of it sitting on the facial nerve. And it's the deep margin, isn't it, that almost always in these types of patients are going to be close or positive. So again, he got through his operation very well, recovered very well, and so he moved on to adjuvant radiotherapy. In him, however, so different from the lady you saw with the adenoid cystic, where I wasn't actually going to treat her neck because she had the neck dissection and that was clear. And after discussions with her, she just wanted the tumor bed treated. In this chap's case, so we've treated, and that this you can see on the image closest to me is that there's the greeny yellow bit on the top, which is where a higher dose has been given because that's the higher risk area. So where the tumor was, where the margins are close. And then I've treated the lower part of his neck because, again, there still remains at risk of him having nodal disease despite the treatment he's had to date. But that receives a lower dose, okay, so, and lower risk of side effects. But very much conforming the treatment to that one side and very much sparing his contralateral parotid as well for function in that way. And, of course, no chemotherapy. He didn't get to his radiotherapy until about 10 weeks because he then had to have dental assessment and treatment and had to have an extraction because of the concerns over his teeth and radiotherapy, and then had problems with healing and infection. So that all, delayed things. But because of his relative risk factors in the pathology, we still felt it was very, very appropriate to give him treatment, and he was very keen to receive it. So just in the last few minutes to talk, I think it's important to sort of emphasize this, is about, we do see quite a bit of metastatic disease to the parotid gland especially, and that's because, of course, it's a very vascular organ. So, when there is hematogenious spread from malignancies, we do see a lot of that in the parotid. And as we're just talking about, some of that can be direct extension, for instance, from a squamous cell carcinoma of the skin on the cheek or, sort of on the ear. But it can also be through the bloodstream from tumours such as renal, breast, or lung, which are not that uncommon. And that's obviously very important to define as to what it is in terms of management. But then you, of course, also get it from head and neck tumours and melanomas and things as well within the head and neck as well. And very much this is where there isn't that set management plan, as I've talked about, that management has to be very bespoke depending upon the primary origin of the actual tumour. And it's where MDT, and dare I say MDT's discussion, can be very important, even though, we sigh when we know that a patient has to go off to another MDT or the sarcoma MDT or the skin MDT because there becomes this MDT inertia and paralysis. But I think for some of these patients, it is very important because it then depends upon what systemic treatments might be available for them. So for instance, if it's a breast patient and they've got a tumor that's hormone sensitive, then all they may need is a change of their hormone medication, for instance, rather than an operation or radiotherapy. So in these cases, it's often surgical excision isn't needed, but it needs to be discussed within that patient and taking into account the staging and where disease might else be. So for instance, if it's a metastatic small cell lung cancer, then a bit of chemotherapy for those patients is not cure, because you're not going to cure them no matter what you do, but they can have extremely useful palliation with chemotherapy. And so coming on to chemotherapy for primary salivary gland malignancies now, again, it doesn't surprise you that there's really no good evidence for its use, but we do widely use it for palliation. And that's because experience tells us that in many patients, when you select the right ones, it does work very well. Because often when you have the patients where there's no possibility of surgery, they've had radiotherapy, or there's reasons why you cannot give them radiotherapy, it can be very, very useful at helping the symptoms like fungation or bleeding or pain that they may have. And this is a lady, I couldn't find a post-chemotherapy image to put on the talk, but this lady had disease all down the front and all down the back, and it was painful and it was constricting her, and clothes were an issue and wearing and things as well. But she didn't have a very long response, but she had a very good symptomatic response for about 8 months with chemotherapy that she tolerated very well. So we should think about it, because they can be very sensitive to it. And we typically use the ones, because these are the ones that are funded, the ones we use for squamous cell carcinoma of the head and neck as well. But I think to come on to sort of the targeted agents and things, because, androgen deprivation therapy isn't actually a trial anymore, although there's talk about an EORTC trial being open in the UK, but I don't see it happening now because it's been happening for about 5 years. But this is looking at androgen deprivation therapy versus chemotherapy, because there's certain salivary tumours like salivary duct carcinomas that can have significant hormone receptors within them. And for those patients, giving them the treatment that we use in prostate cancer can be exquisitely, a good treatment, and can therefore, require the patients not to have chemotherapy or radiotherapy and keep things controlled for years in some patients. But there are a hell of a number of targeted agents, and we know certain salivary gland tumours express HER2 status, and that they can have Herceptin, the treatment that we use for breast cancer, trastuzumab, in certain cases. But the problem is it's not funded, within the NHS. But I know patients who have had it privately and had good responses. But these are very, very rare incidences. And there are talks about getting a clinical trial up and going in the UK, for instance, for adenoid cystic carcinomas, because again, that they've got very specific molecular markers as well. So I'm going to finish with the third slide that I started with, and it's really just to emphasize again that sort of for early stage, low grade disease, we're looking at single modality of treatment, but consider the radiotherapy if there are certain adverse pathological features post-surgery. But for the advanced stage high grade, you should be, from the very beginning when we're seeing these patients is telling them that they will require biomodality treatment. But consider primary radiotherapy when patients decline or are not suitable for surgery in the first instance. And remember that chemotherapy can be a useful tool within our treatment armamentarium for these patients. So thank you very much.